So we will kind of go through the steps of corneal crosslinking and the indications for corneal crosslinking, talk about keratoconus a little bit. And Dr. Kim is going to actually send me a text when we're ready to throw back to her and the patient, and then we can watch kind of the conclusion of that procedure. So I want to thank everyone for taking the time to be with us today. Let me share my screen so we can get started on these PowerPoints. So as I mentioned, we're going to talk about corneal crosslinking, and very excited to chat about this new procedure. So we'll first go over a little bit of an overview of keratoconus, and we'll talk about cross-linking and what are the kind of the background of it and how it's working. We'll talk about some phase 3 study data that have been provided to us by Avidro, just to kind of help us understand a little bit more about the safety and efficacy of this procedure. We'll talk a little bit about pre-op considerations, which are very important in helping to choose patients and figuring out best case scenarios and kind of managing expectations for the patients to have. And then we'll talk a little bit more about the FDA approved protocols, and lastly about post-op management and complications and kind of things to consider going forward. And then if we time this properly, we should throw it right back to Dr. Kim at the end of that. So let's continue on here. So an overview of keratoconus, something we've all studied quite a bit, but keratoconus is a bilateral progressive corneal ectasia, which results in an irregular astigmatism and loss of visual function progressively, usually with an onset of teenage years or adolescence. It affects about 1 out of every 2,000 people in the US to some degree. The incidence of keratoconus actually might be higher than that, considering that there have been recent advances in imaging and diagnostic techniques, specifically in the last few years. So, a lot of times we'll see patients and we can't really explain a lot of the changes that are going on with their prescriptions. And, now with better imaging techniques, we can kind of zero in a little bit better on the diagnosis. So the clinical diagnosis of keratoconus is typically made using slit lamp findings and observations of the central or the inferior cornea. Computerized video keratography has been a little bit more useful in detecting early keratoconus and allows us to follow the progression a little bit better. Excuse me. Ultrasound pachymetry is also used to measure the thinnest zone on the cornea, and there are some new algorithms out there which are using computerized video keratography that'll help detect subclinical or suspected keratoconus. Like I mentioned earlier, sometimes those patients where you just don't really know what's going on, there's a lot of new algorithms and techniques to kind of discover that. So as I mentioned, the slit lamp findings are very important for keratoconus. Voigt striae, Fleischer's ring, Munson sign, corneal scarring, and Rizzuti sign are all some of the ones to watch out for. We'll go over those in a second. And other diagnostics are irregular keratometry Myers, scissor reflex, increasing astigmatism, and a progressive loss of uncorrected and best corrected visual acuity. And finally, of course, we'll look at the topography and the tomography and identify any irregularities there. So Voigt striae are vertical fine lines. They're whitish lines that are embedded in the deep to posterior stroma and part of Descemet's membrane. And they're commonly found in patients with keratoconus. It may be asymmetric depending on the degree of keratoconus in each eye, and there's usually a positive correlation between the orientation of the lines with the steepest axis of the cornea, and the mechanism is thought to be related to the mechanical stress forces that are being exuded upon the collagen lamellae, which are radiating from the cone apex. And they can temporarily disappear with external pressure to the globe. Something else is Fleischer's ring. Seems like Dr. Fleischer's been at it for every diagnosis of every different types of disease, but for Fleischer's rings, they're partial or complete iron deposition rings in the deep epithelium which encircle the base of the cone. And it's very characteristic in eyes with keratoconus. And you can kind of see, I've put an arrow there to show the yellowish, darkish, dark brown colored ring. It's typically best seen with a cobalt blue light, but that's very eponymous for keratoconus. Munson sign is a V-shaped indentation which is observed in the lower eyelid when the patient's gaze is directed downwards. And this is characteristic of an advanced keratoconus, and it's caused by the cone-shaped cornea pressing down onto the lower eyelid. So you can see in this photo, the patient's looking down, and you have the inverted V, or the V pattern that is seen kind of at the base there. Apical corneal scarring, which is kind of faintly shown in this photo, it can result as the complication of corneal hydrops, which are found in some patients with keratoconus. And lastly, Rizzuti sign is a sharply focused beam of light near the nasal limbus, which is produced by lateral illumination of the cornea in patients with advanced keratoconus. One of my attendings at residency was actually the founder, the inventor, the discoverer of Rizzuti sign, his granddaughter. She was one of our attendings. So this was a pretty hot button topic for us as we were going through our training. So some of the risk factors for keratoconus can be broken up into genetic versus environmental. With genetic, there's typically an indication of a family history. It can also be related to Down syndrome, connective tissue disorders, retinitis pigmentosa, and environmentally it can be exacerbated by things such as eye rubbing, allergy or atopy, or sleep apnea. So the management of keratoconus has kind of been this long-standing algorithm of progressing as the disease progresses itself. And one of the things that was found across the board was that the treatment options really didn't halt the progression of keratoconus. It basically just adapted to the severity of the disease. So glasses, soft contact lenses, specialty contacts, intrastromal rings, and finally penetrating keratoplasties, corneal transplants, were typically how things were managed, and has been the standard for some time. Patients with early keratoconus may function well with traditional eyeglasses. Rigid contacts, specialty contacts, and scleral lenses are helpful to create a smooth refractive surface, and they can temporarily mask the corneal irregularity based on the severity of that. If that fails, we typically will move to intracorneal ring segments, which will reduce or eliminate some of the myopia and astigmatism that are found in keratoconic patients. And lastly, in severe cases, like I mentioned, penetrating keratoplasty is one of the mainstream treatments for severe cases. Just a little aside about corneal transplants. Some of the long-term data has shown that about 73% of grafts fail within 20 years. 98% fail at around 30 years. So there's the potential for multiple transplants. And as of 2016, keratoconus was the fourth most common indication for corneal transplants in the United States. The Eye Bank Association of America had noted about 8,000 transplants per year in patients with keratoconus. So crosslinking is indicated for progressive keratoconus, and it's important to diagnose early and monitor for progression before visual function is lost. One of the early signs of keratoconus is astigmatism variance between the eyes. Some of the other things that you can see are stromal and epithelial thickness changes, posterior elevation changes, wavefront aberrations, and topographic changes as well, including inferior steepening and irregularity indices. So we typically will diagnose and monitor the progression using some of the advanced diagnostic equipment that we've got available, including the Placido topographer, the Scheimpflug, anterior segment OCTs, which will help to provide a detailed cross-section of the cornea. And we'll get into this a little bit later, but the criteria for treatment are the progression of the disease and the minimal corneal thickness. So these are all really helpful to kind of help us assess when and how we should treat and if we can treat. So the mechanism of corneal crosslinking is such that we're basically using ultraviolet light and riboflavin, which are vitamin B2 drops. The absorption of the UV light by riboflavin generates radical riboflavin and singlet oxygen to form corneal crosslinks. And crosslinking, like I said, it creates new corneal collagen crosslinks, and it results in a shortening and a thickening of the existing collagen fibrils, and it leads to a stiffening of the cornea. It refers to the ability of collagen fibrils to form strong chemical bonds with adjacent fibrils. And collagen crosslinking occurs naturally as we age due to an oxidative deamination reaction that takes place within the end chains of the collagen. And it's been hypothesized that this natural cross-linkage of collagen explains why keratoctasias progress usually rapidly in adolescence or early adulthood, but they stabilize in patients after middle age due to the oxidative deamination reactions. The absorption of UVA by riboflavin, it generates radical riboflavins, like I said, and it helps to form crosslinks. So the first clinical use of cross-linking was in 2003 when Wallensack, Sperl, and Seiler published the results of a 23-eye and 22 patient treatment cross-linking. And the goal was to evaluate whether the effect of cross-linking on the patients with moderate or advanced keratoconus was meaningful and significant. In 16 of the eyes, 70% that were treated, regression with a reduction of the max K's readings of 2.01 diopters and the refractive error decreasing by 1.14 diopters was found. So Avidro took some of this information and they enrolled in an NDA submission which encompassed data from 3 prospective randomized parallel group open label placebo-controlled 12-month trials that were conducted in the US to evaluate the safety and efficacy of riboflavin and UVA for performing corneal cross-linking. These trials included 205 patients with progressive keratoconus and 179 patients with corneal ectasias following refractive surgery such as LASIK. The schedule of assessments for these trials was to perform a screening or baseline examination, and then day 0, so on the day of the treatment or the randomization, 1 day post-op, 1 week post-op, and then 1 month, 3 months, 6 months, and 12 months after treatment. And the primary endpoint that they were measuring was the Kmax as measured by keratometry. So the efficacy analysis helped to show whether or not the progressive keratoconus was improved at all. So cross-linked treated eyes showed an increasing improvement of Kmax from months 3 through 12 with an average reduction of 1.4 diopters in one study and 1.7 diopters in another study at 12 months. The sham eyes, which were the placebo-controlled eyes, demonstrated a steepening of Kmax from months 3 through 12 with an average Kmax increase of 0.5 diopters in study 1 and 0.6 diopters in study 2 at month 12. So definitely showed an improvement in the Kmax and the corneal steepening. Corneal cross-linked treated eyes showed an increased improvement in Kmax from months 3 through 12 with an average reduction of Kmax of 1 diopter in study 1 and 0.5 diopters in study 3 at month 12. And these are for corneal ectasias following LASIK and refractive surgery. So again, did show an increasing improvement in the Kmax during that time. The placebo-controlled eyes that were measured during the exact same time frame showed an average Kmax increase of 1.0 diopters in one study and 0.5 diopters in another study at month 12. So again, we're seeing the effects pretty well in both keratoconus and corneal ectasias after LASIK. So some of the common ocular adverse reactions that were reported in the cross-linked treated eyes were corneal opacity, punctate keratitis, corneal striae, epidefect, some eye pain, reduced visual acuity, blurred vision, dry eyes, and photophobia, particularly in those with LASIK. The majority of the adverse events were reported to have been resolved within the first month. As you saw with that list, a lot of these are pretty standard post-op complications from any sort of manipulation of the eye. Corneal epidefects, striae, punctate keratitis, photophobia, dry eye, and decreased visual acuity took about 6 months to resolve, and corneal opacities took up to 12 months to resolve. So in 1 to 2% of patients, the epidefects and scars continued to be present after 12 months. In 2016, the FDA approved corneal cross-linking for progressive keratoconus and for corneal ectasias following refractive surgery. So that was a pretty big move by the FDA. So with the FDA approval, Avidro is one of the first companies, and that's what we use here at Swagel-Wooten, and I know that's what they're using at Colorado as well. The Photrexa viscous, we'll go into all of these components later. The Photrexa solution. So the viscous is a riboflavin product that is also in 20% dextran ophthalmic solution. And the Photrexa is just the riboflavin ophthalmic solution by itself. And the KXL system is what delivers the UVA light. And this, like I said, was the first FDA-approved therapeutic treatment. So some things to consider preoperatively are setting expectations for the patient. It's important to develop a roadmap of care. Progressive keratoconus and corneal ectasias following refractive surgery, they have a significant impact on the patient's quality of life. it's really important to diagnose early and to monitor for progression before visual function has been lost. Crosslinking is a step in the continuum of care for these patients. It doesn't eliminate the need for continued medical care and visual management, but it does slow down the progression of the disease and can even halt it in most cases. So defining treatment goals, it's very important to talk to the patient and establish that crosslinking is not a refractive surgery. It's a medically indicated procedure to treat an orphan disease. Treatment is not intended to eliminate or reduce dependence on refractive correction, but rather it will stabilize it. Contact lenses and spectacles are still required, and regular eye exams obviously are still needed to monitor the disease state. The objective of the procedure is to stiffen the cornea to limit the progression of the disease. Educating patients regarding the time course of post-op healing process is big, and I'm sure Dr. Kim will speak to that as well with her patient that she's working with right now and many others that she's treated in the past. On average, the steepening of the Kmax is observed at 1 month post-operatively, but then it flattens out after that through 12 months. So for that first month, sorry, I'm just going to jump back. For that first month, you can expect a little bit of a decreasing visual acuity before it starts to improve thereafter. In specific populations, pediatric use is FDA approved above 14 years or older. There are some clinicians on the East Coast and in Europe and Asia that have applied this to patients who are 9, 10 years old, but the FDA approval is 14 years. And cross-linking can be performed on patients below the age of 65. A lot of that is due to the fact of the deamination reaction that can help to create those cross-links. It doesn't really apply to patients later in life. And the safety has not been evaluated in patients who are pregnant and or lactating, and so cross-linking should not be performed on pregnant women at this time. So kind of walking through the patient's perspective a little bit, what to expect on the day of treatment. From our standpoint, from the clinicians, Photrexa is required. The Photrexa viscous is also required. Pre-op and post-op meds, a lid speculum epithelial removal tools, the UVA light system, and the treatment activation card, all of which Dr. Kim has kind of displayed to us early on. And these are just kind of some pictures of the different materials. So on the left, you have the Photrexa riboflavin solution, and you have the Photrexa riboflavin viscous solution. On the right, you have the UVA KXL machine that delivers the ultraviolet light to induce the corneal cross-linking. So this was pulled from Evidro's site, and it was kind of a little bit of a guideline of treatment. So as Dr. Kim talked about in the beginning, you remove the epithelium, can either be done by alcohol or brush, and the Photrexa viscous is dropped every 2 minutes for 30 minutes. And at the end of that time, you check for what's known as a riboflavin flare in the anterior chamber, and this can be done by the physician administering the drops. If the yellow flare is not detected, which indicates that riboflavin saturation is there, then you continue to add 1 drop of the viscous every 2 minutes for an additional 2 to 3 drops. And then you recheck for flare and you repeat as necessary. Ultrasound pachymetry should be measured thereafter, and if it's less than 400 microns, you give 2 drops of the Photrexa solution every few seconds until 400 microns has been achieved. And irradiation should not be performed unless the 400 microns is achieved. So 30 minutes of UV exposure with the KXL system is what is needed, and during that time, when the light is applied, we will continue to apply the Photrexa viscous to help stiffen and stabilize those bonds. So I talked about this a little bit, and Dr. Kim obviously showed us kind of how we do that. Like I said, it's important to check after 30 minutes to see if the riboflavin flare is there to show that enough of the protein has been absorbed by the cornea. And once you see that, then you can proceed to the UV light. And again, we'll irradiate the eye for 30 continuous minutes. And during this time, again, it's important to continue the Photrexa viscous to help both protect the eye and to help to create the new bonds between the corneal the collagen bonds. Some potential complications of the procedure, like I mentioned, are some stromal edema temporarily, stromal haze, corneal scarring, and sterile infiltrates. Infectious keratitis, and bacterial, protozoan, and herpetic etiologies are also found. Diffuse lamellar keratitis in a post-LASIK patient is typically found as well. Postoperative management. Some things to consider. A bandaged contact lens should be applied. Obviously, you've debrided the epithelium. And surgeons may apply their standard of care for postoperative management of PRK patients, as the beginning part is basically the same procedure. This can include antibiotics, steroids, NSAIDs, or lubricating drops. And it's sort of up to the physician's discretion regarding the appropriate care for the patients, but typically that's what's followed in most people. Patients should be advised to not rub their eyes for the first 5 days after the procedure. They may be sensitive to light and have a foreign body sensation. They should also be advised of possible discomfort in that treated eye, and that sunglasses may help with light sensitivity. If they experience pain or sudden decrease in their vision, they should be advised to contact the eye care provider, obviously. And if the patient's bandage lens, contact lens comes out, patient is to call the doctor. So like I mentioned with our, in the beginning, the cross-linking follow-up schedule is typically the day after surgery, the week after surgery, 1 month after surgery, and then months 3, 6, and 12 are when you kind of evaluate using topography and visual assessments. And the optometric co-management of corneal cross-linking is of utmost importance. Early diagnosis, incorporating routine screenings for keratoconus and corneal ectasia is huge. Pre-op education and counseling, managing the expectations of the patient's outcome, and the post-op regimen are all very, very important as well. The time course for the corneal curvature changes that occur after cross-linking, initially you have a steepening followed by a gradual flattening. And the long-term goal of cross-linking is to halt the progression of the disease altogether. So like we mentioned, the beginning, you have a little bit of a visual distortion, and then it tends to get better afterwards. Typically, we'll evaluate, like I said, at months 3 and sometimes even a little bit before. And if things are stable, then the patients can be fitted for contacts and proceed as usual along that previous roadmap that we saw. Early diagnosis is very, very important because as the disease progresses, it happens a lot in early childhood and adolescence, and catching this early is a big help to getting excellent visual outcomes in the future. And typically 1 eye is done at a time, and they'll check at around month 3 or 2 to make sure that the patient is stable for the next eye. So real quick, while we're waiting for Dr. Kim, I just wanted to quickly talk about the cost to the patients. It used to be really costly to get this done. Keratoconus in general is very expensive because of the high amounts of changing visions and like we mentioned, the different types of contacts, potential transplants. The costs all tend to add up. The lifetime out-of-pocket costs are in excess of $10,000 for about 30% of people. And that's basically where we're at. So what's been really great is that third-party coverage has really increased over the last several years. Patients and practices have already been filing insurances on their own, and some payers have begun to cover. And it's really easy to show disease progression and differences in prescription changes. And a lot of these insurance companies are really helping out with that. So here's a list of just a few that we found during our researches, but we've got all our amazing staff getting all that information for us. Avidro, they've come up with a few programs to also help patients, because I think having an understanding for the patient that this is a financially manageable option, it really will help to improve their access to this procedure. Here's some of the frequently asked questions that we've kind of put out at Swagel-Wooten. We kind of go through the three-step procedure, and I can email this or send this to anyone who'd like to kind of create one for themselves. We talk about the procedure, we talk about who's a candidate for the procedure, and we're very clear about corneal ectasias or keratoconus. We talk about insurance coverages as well, which are all the questions that patients have asked us and other referrers for a long time. In conclusion, it's a very, very helpful treatment, and it can really benefit the patients a lot. It can help to prevent lots of costs and treatment options in the future. And I just want to say thank you from Swagel-Wooten. So let me stop sharing, and we'll pass it over to Dr. Kim. Dr. Kim, the floor is yours.
Okay, hi everyone. So we're fully saturated, and if you look here, we have a slit lamp here under. This is actually our LASIK set, our wavelight suite, but we're using this slit lamp here, and you can see our patient here. He's fully saturated with the Photrexa. So we're going to pan up to the monitor there, and I'm just taking a look at his cornea. And just confirming that we're fully saturated, and that looks great. He's penetrating most recently 441. So he started out at a pachymetry of 520, and we're at 441 now. So why don't we go ahead and you can see from Dr. Aurora's talk that this is the unit here, and it's a small little cute Star Wars robot looking thing. And why don't you just do a close up there? Want to turn the lights off?
Yeah, perfect. And we're starting the treatment now. Just want to get the crosshair is fully lined up, and again we'll continue with a drop every 2 minutes for half an hour. It has a nice little remote control so you can keep your patient completely centered and focused on the light.
Right, let's do a real quick zoom in one more time.
It's kind of important because the young patients get nervous and have a
So that remote is amazing. All right, and we'll be doing this now for the next half hour. So Dr. Arora, we'll let you continue your amazing lecture. And once this part is finished, once we go through these next 30 minutes, we will place a bandage contact lens on the patient, obviously for comfort. And then we'll see him tomorrow. We'll see him at a week. We'll see him at a month. And typically we won't recommend moving on to the next eye until, depends on the patient, but 3 to 6 months later. Okay, Dr. Arora, we're gonna say goodbye. Our team's gonna say goodbye.
Thank you so much, Dr. Kim. Thanks, team. That was awesome. That was right on cue. So really appreciate that. I just wanted to thank everyone so much for coming to this talk. And I really appreciate your time and attention. I know it's a little bit late in the day. I know we're all kind of back to work and getting in the swing of things, but I had a great time doing this, and I hope you learned a little something from it. If you have any questions, you can just drop me an email or reach out to Christina, and I'm happy to, sorry, my video is off again. Oh, and it looks like we have Dr. Kim back, I think, so I'm going to toss it back to her. No, we don't.
I was just saying goodbye.
Thanks
for having us.
Thank you so much, Dr. Kim. That was awesome to do it live while we're talking about it. So thank you so much for that.
Yes, it was our pleasure. Yeah, thanks for getting this together, you guys.
Awesome. Cool. So yeah, like I said, if anyone has any questions, going forward, please feel free to email Christina. You can send me an email. It's jay.arora, my first and last name, at swei.az. Or sorry, sweiaz.com. I'm sorry, I'm new here. So anyway, thanks everyone, and I hope you have a good night.
Thanks so much, Dr. Arora. Thank you, Dr. Kim.
Thanks, everyone. Have a good night.